Welcome to another edition of ECW Podcast. My name is Brian Saal. I'm your host for today. We're here in Pawleys Island, South Carolina with Dr. David Haseltine.
Sure.
He's with Pawleys Pediatrics in adult medicine. And today we're going to be talking about chronic care management. Thank you for joining us, Doctor.
Yes.
We really appreciate your time.
Pleasure to be here.
We talked a little bit earlier about giving a brief description of what the CCM program is. Would you, before we start, could you just give us a brief overview of it?
Sure. Chronic care management was started out by the Centers for Medicare and Medicaid probably about a year ago or so, and it's designed to give people who've got 2 or more chronic medical problems some additional help in terms of either a nurse care manager or additional nursing staff who can actually help guide them through dealing with those problems on a regular basis.
Okay. And how did you first learn about it?
Yeah, I think I probably first learned about from one of these throwaway journals that everybody gets in the mail, and you toss them, you read them, you say, oh, that's a little interesting, and over time you start seeing more and more articles, and eventually you say, hey, that really might be something that could benefit my patients.
Sure,
and so
yeah.
we took it from there.
And did you, for preparation, what did you actually do to begin to prepare for putting this program into place?
Sure. Well, we actually have an outstanding staff here, so we had our nurse manager at the time, Tawny Terzak, as well as our office manager, Lynn Reed, and eventually we hired a nurse care manager who would be overseeing the program. And so we basically set them loose and said, hey, we as physicians are really interested in doing this program now. Please go out, research everything that you can, and come back with us or a plan in which we can actually begin work with this, hopefully in a few months. So 3 months later, they came to us with a plan, and we started getting started from there.
That's fantastic. A team approach like that is really, it's different than what I've heard in the past. That's really certainly a great way to approach it. You mentioned that you had your physicians were involved with it, obviously. Did you have complete buy-in from the physicians? Was there any pushback from providers?
Yeah, I think 2 of us are pretty interested in it to begin with, and some of the rest are a little bit more reluctant to engage and want to see how it went before moving forward. And I think that probably is still reflected in our numbers. I think a few of us are a little bit higher than everybody else at the time.
And staff as well, was there any, were they anxious or were they excited about getting
staff
into
really
the
didn't seem to have too much difficulty buying into the program. A lot of it's what they're doing already, so the only additional thing they need to do is start keeping track of their time, and the ECW product offered a fairly easy way for them to do that. So as a result, it was not too hard to get staff buy-in.
That leads into a really good question, and as we mentioned earlier, there's a 20-minute time period that needs to be filled in between patient visits. What's your staff and what are your providers doing to fill those 20 minutes?
Sure. It really can be anything that you're already doing, but we take it one step further and have a nurse care manager who actually goes through and calls the patient. So the things that we're already doing that we could end up meeting those 20 minutes included refilling medications. We could have people who are calling back labs and going over the results with them, tracking down outpatient referrals and whether those referrals were being made on a timely fashion. Also, if we had one of our certified MAs calling and making sure that we got all of the paperwork back on the chart, any of that would count, and those were some of the things that we were already doing. But we want to take it one step further and say, we really see a great opportunity to improve people's care, and so we hired a nurse manager for this particular endeavor, and she was able to call people really on a monthly basis and say, how are you doing? Are your blood sugars really under good control? Is your heart failure doing well? Are you watching your diet? And what can I do to help you meet those sorts of goals that we weren't able to do before?
I may have gotten a little bit ahead of myself by asking you that question.
Sure.
Let me take a step back and ask what the process is that that you use to enroll a patient into the program, or even get them interested in the program up front. What do you do with the patient on that?
Yeah, we start even before they come in the office. So we have some papers that we mail to the home, just so they have a good overview of what the program is. It's about 1 or 2 pages. It tells them what chronic care management is, what they could expect, how the nurse manager could help improve some of their care issues. And so that really gears them up so that when they're present in the office, our MAs who go in and speak with them have the opportunity to go in greater detail about what the program is and the benefit. We actually hand them something in the office that says, here's what the program is, so those people who are better at reading rather than listening might do a little bit better with that. And then they have a chance to read through that all before the physician even comes in the room. So if we really do a good job, and some of our certified MAs are excellent at this, then they've really teed up the program so that all the physicians physician has to do is kind of basically hit the home run at the end.
Yeah.
So, if the bases are loaded, then the physician at the end just has to say, hey, here's what we're going to plan on doing, here's how it can help you, and here are the charge fees and how you would end up revoking the process if you needed to. Here's how we think it would be of good benefit, and then decide where people can stand up. So altogether, it doesn't take too long once everybody's done their work ahead of time.
So there is a consent form that needs to be signed. Yes. Is that something you send out with the original packet, or is it something that's presented to the patient when they're in the office? Or
no, we present that in the office. Usually the physician will take that in at the very end and say, here's what we've discussed, and if you're interested, go ahead and sign up and check yes, and then if you're not interested, go ahead and sign up and check no.
Okay. And overall, what's patient reaction been like in general?
Sure. I think patients have really found it to be a very positive experience. In fact, we have a number of them come back and say that our nurse manager is very pleasant. She's a person by the name of Catherine. She has outstanding patient interaction capabilities. I mean, she really does a good job of getting to know who these people are, spending her time with them on the phone. And so a lot of times they come back and say, hey, doc, you know, she spends more time with me than you do. So it actually has been a very pleasant thing for most of them. And a lot of them enjoy speaking with her on a long-term basis. In fact, I've even had one or two of the cardiologists come back and tell me that they've actually had a lot of interactions with their patients who they see some improvement in their numbers, and the patients say, yeah, I really enjoy this new program that's helping me out.
That's great. So it's so helpful when you have that level of staff available to you to help the practice out. I'm here talking about chronic care management with Dr. David Haseltine. We'll be back in just a second. Thanks for joining us.
You know, it's moments like this that make me go another year. 4,500 attendees, 49 states, 5 countries for the first time, 450 clinical works engineers, support staff, trainers, product specialists. Mingle with them, ask them questions, 50 exhibitors, hands-on training. It's just full. The most exciting product showcase, 16 plus demonstrations for you. We will blow you away.
Don't miss this extraordinary 3-day event, which we'll cap off with an amazing night of dancing, music, entertainment, networking, and much more. Come join us for our 2016 National Conference in sunny Florida at the Orlando World Center Marriott from October 21st through the 24th. For more information and to register today, visit us at specialevents.eclinicalworks.com.
Welcome back. I'm Brian Saal. I'm here with Dr. David Haseltine. We're talking about chronic care management. A few minutes ago, we were talking about some of the positive aspects of signing people up. Can we talk a little bit about some of the hurdles that you've had to overcome in dealing with patients in this level?
Well, there are a number of things that we had to watch out for. I think first is there are a number of restrictions that CMS has that everybody needs to be aware of. You do need to make sure that you've got somebody on call 24/7. So if you don't have that in place, then it's important to make sure that that's undergone. You also need to make sure that you've got the capability of sending a summary of care electronically to some people. We initially didn't have that capability with the Health Information Exchange area, so we've created our own kind of workaround in that we can send a CCD document that ECW creates through a secure email to anybody who requests it at any time. So it did take us a while to wrap our thoughts around that. You know, the faxing is not allowed anymore for this, so that is something people need to be aware of. And so those sorts of things are important for people to really do their due diligence and check and make sure that you're not going to get caught up in something that CMS is requiring ahead of time. We've also had some trouble in terms of getting people to sign up. I mean, there is a fee for doing this, and sometimes it is difficult to convince people to pay for things that some of them have been already receiving. And then also some people are very low income and don't have the funds to do even $8 a month, which the fee may be. So it is difficult. We do wish that CMS would consider or reconsider some of those things. And some people obviously don't seem to see much of a benefit in it, and so that's okay. We hopefully do try to prove to them that for our benefit. We've had some people who've been on the fence ahead of time that have been through the program and say afterwards, you know, gee, I'm really glad that we had that opportunity. I actually had one lady come in today who had a urinary tract infection. She said, you know, I was just going to stay home, but the nurse care manager convinced me I really needed to come in, and she did have some problems that were beyond her urinary tract infection that needed to be addressed. So,
oh, that's fantastic.
There were some benefits there.
So one of the things you mentioned were, in terms of requirements as well, are care plans.
Sure.
Care plans are required. You mentioned that you're using sort of an abbreviated version of the ECW one. Sure. Can you tell us how you use care plans and sure. within the program?
Sure. So we initially have the doctor set out at least 2 goals that they want their patients to end up accomplishing through the nurse care manager. And then she will take the existing care plan that we have from ECW. We had another physician go through and cut it down a little bit. It was initially taking her about 2 hours to go through, and that was a little hard for, I think, everybody involved, with the patients on the other end of the telephone and her as well. So we've got to the point to where there are probably about 30 minutes of key questions that we hope she'll be able to answer, and then that makes it easier for the physicians to review as well. And then along with those 2 goals, those really comprise the initial care plan that we expect people to adhere to, at least for the first few months, and can also change at any point in time depending on how well they're doing.
Well, you're mentioning ease of use with the care plans. Can I get you to elaborate a little bit on your use of the CCM module within ECW and its ease of use or not ease of use, depending on what your experience has been?
Yeah, no, I think it's made something that would otherwise be very difficult to do much easier to do. So, you know, you can imagine having to sit there with a stopwatch and click it every time. And if you tried to write things down on paper, then it would be, after a while, you'd have these mounds and mounds of paper and stopwatch tickers and things like that, and it'd be very difficult to figure out how to do. We did actually try at one point creating Excel spreadsheets to do this, and they failed miserably. It really was hard to coordinate that with the chart and get everything together. So being able to have something that's already included with the patient's chart, that has just a button that you can click at the end, and then automatically pulls up a list of responses that you can categorize the time that you spent, makes it much easier in terms of managing this, and trying to figure out also who have you not been able to get in touch with, and whom do you still need to be able to get in touch with for the rest of the month. That's a very good, helpful means that the ECW program offers us as well.
Sure, it allows you to have complete follow-through on that patient. It's funny because you say about the spreadsheet solution, there's not a provider I've talked to that's worked for. So. Kind of a strange question. Now, the patient can actually sign up for this program with almost as many providers as they like.
Yes.
So if a patient comes out after an MI and they see their cardiologist, the cardiologist can sign them up, and then when they come to see you, you can sign them. Have you ever had any issues with that sort of?
We haven't actually. We're probably one of the first people in the area to start the program, and as a result, we don't see that many subspecialists are doing that at the present time. So for us, from a primary care standpoint, being able to be first in there and really provide the all-encompassing care that we think our patients really need has been the opportunity to do really well. And I can foresee in the future it might be a possibility at some point, but right now we're not seeing any problems in that respect.
Good. Good. I guess the last question, because we're pretty much down to the wire now, overall, what would you say, if you were speaking to another provider or another group of providers, what would you say are the must-dos and the must-don'ts, or don't do? Sure. What are your tricks of the trade that you would provide to these folks?
Okay. Well, I think there are several things that they need to do. One is, again, really know in detail what the requirements, but 2, be accepting of change, because this really is a change in how we do business. And if you look at how healthcare has been set up over the past few years, we've had some big shifts in medicine. In the 1960s, it was with the onset of Medicare. In the 1990s, everybody started moving into managed care environments. And here we are now, we're shifting towards value rather than volume. And so this really is a good step in moving down that pathway. It allows you to kind of figure out, how can I begin providing services to people on an ongoing basis rather than just the one time that they're in the office. And so for us, I think it's a necessary step in making sure that we're a viable practice and making sure that we're still here to serve our patients for the long term.
Sure, that's a very good point about how it's sort of a very good first step in moving away from that fee-for-service into the value-based payment model. Doctor, you just made a very good example of how this has had a positive impact on patient care with the person who had the urinary tract infection. Have there been any more dramatic episodes other than that one?
Sure, we really did have one. And in fact, this was a guy who had diabetes and had high blood pressure. He was actually fairly well controlled. So in the beginning, when we presented it to him, he said, you know, yeah, sounds like a good program, but I think I'm doing okay, and I'll probably sign up for a month or 2, but I expect to stop in about a month or 2. I don't think it's going to add very much benefit. And then actually about a month later, the nurse manager called him up, and she said, "How are your blood sugars doing?" He said, "Oh, they're about 100, 110. She said, "Oh, that's great. How's your blood pressure doing?" He said, "Oh, it's about 120 over 60s." And she said, "Oh, that's great too." And so at the very end, she said, "Is there anything else that's going on?" He said, "Yeah, I've been having a little bit of chest pain, and I think it's just due to my nasal spray, and I'm going to ignore it." So she actually called me up and said, "What do we do about this chest pain?" I said, "Let's get him in right now." And his EKG was not entirely normal. We had him for a stress test. It showed another problem. We got him down for cardiac catheterization, and he needed a 3-vessel bypass.
Wow.
So this is a guy who, if you think about it, if he hadn't been caught by the nurse care manager, really either one of two things would have happened. So he would have had a massive heart attack and probably would have died from that, which would have been a really bad outcome for him. Or worse, for the hospital system, you know, if he had had a heart attack and had been left with congestive heart failure because he waited too long, he could have been in and out of the hospital for the rest of his life trying to manage care from that. But as it is, he is now up, walking, perfectly fine. Sure, he had to have a 3-vessel bypass, but he's perfectly functional, he's enjoying life, and the hospital system has the benefit of not having to do all this chronic management problems for lifelong. So it really has been an outstanding SAVE program for him, and we've actually had a hard time trying to get him from to stop bringing in gifts for some of the practice as well. But he's a great guy, and we're glad that he's doing really well.
That is an absolutely amazing story. Absolutely just an amazing story. And thank you so much for sharing that with us, and thank you for spending your time with us here today, Dr. Haseltine. I'm Brian Saal. Thank you for joining us on the ECW Podcast. You can see more ECW podcasts on iTunes, YouTube, and on ECW.com. And please keep in mind that the National Conference is coming up this October. It's going to be in Orlando, and as always, it's going to be a great time. Registration is open. Take a look. Take care, everybody. Bye-bye.
This broadcast and its contents are the sole property of eClinicalWorks and are protected by federal law and international treaties. You are strictly prohibited from making a copy of, modification of, or form of rebroadcasting or re-encoding this broadcast without prior written permission from eClinicalWorks Public Relations, except as may be permitted by law. This broadcast is provided for informational purposes only. It is intended as a personal, non-commercial use. Product specifications are subject to change without notice. Please contact eClinicalWorks Public Relations with any questions. eClinicalWorks V10 EHR is ONC HIT 2014 edition certified as a complete EHR. eClinicalWorks V10 CC 2014 955447-1.